Hello everybody and welcome to the Performance Health webinar. I'm Nicola Goldsmith and I am a hand therapist and occupational therapist, and I work as the clinical ambassador for Performance Health. And today we're going to do a webinar predominantly about taping. And I think I'm locally known by my patients and certainly by the doctors that I work with as the taping queen. And I seem to find a reason for taping for most people, to be honest. And of course, I'm covered in it myself very regularly. So I've got my trusty, lovely Rachel with me, as always, to be my patient victim, whatever you'd like to say.
Yep.
And I'm just going to do a real quick run through very briefly, the theory. This is a day's course that I'm trying to get done in 45 minutes to give us time for some questions at the end. So it really is going to be a whistle-stop tour, but we'll try and get through as many applications as we can. So my goal for the webinar today is going to be the aims of the webinar. So to explore the theory of the knowledge around kinesiology taping, to explore some of the common techniques and so that we can share a language around it. We're going to then have an opportunity for you to observe. But I did say in the blurb beforehand, get some tape, have some scissors. So I hope you'll actually be able to tape along with us, with a colleague, so you can actually practice while we're doing things together. We're going to try and run through edema, scarring, muscle enhance, inhibit, and some other ideas as we go through. So where did it start? So Kenzo Kaze is a chiropractor from Japan, and he invented this tape a very long time ago, in the early 90s, but it took a while to make its way across the planet, and he designed it very specifically to enable or to mimic the outer layers of the skin. And when you look on the inside of the tape, if I take some tape here and you look at the layers here, he actually designed it very specifically to follow contours of the skin and the fingerprint, the elasticity of the outer layers of the skin. So this isn't by accident, this is actually by design. So let's think about how to do a few of the skills. So obviously, one of the things we want to do is try and get the tape to last as long as possible. So we want to be able to talk about the tension on the tape. And I see people really who want to overstretch the tape. It still works. And one of the things with little tension, one of the things in Kaze's original book is that he does mention that he thinks that if you have a tendency to over stretch the tape, it's probably less effective than under stretching it. So I would recommend always veer on less is more. Okay, so never put tension on the anchor. So if we have a piece of tape, then the active part of the tape is always going to be this central part. And we're going to call each end the anchors. So the anchors go onto the skin with no tension on them whatsoever. And the active place part of the tape is this central part. So we want to look at the amount of stretch. So if I fold this back, just as an example, so you can see, now I could go to full stretch, I could go to no stretch, but I can go anywhere in between. And one of the things with this THERABAND tape is you can probably see these shapes here that are sort of indicated with a slightly wider edging. Now, the really nice thing about these is when you stretch the tape and the smaller one ends up as a hexagon, then this is 25% stretch of the tape. When you stretch the tape and the larger ones go to a hexagon, a true hexagon, this is 50% stretch of the tape. So as far as I'm aware, it's the only tape that gives you that sort of visual feedback as you are stretching. So we're talking really here, you can see more full stretch would be 100%, severe tension around 75%, Moderate 50%. It's rare that I'll ever use anything more than 50%. Light or paper off tension is between 15 and 20%. Very light up to 10, 15%, and then no tension at all. And there are different applications which have a different amount of stretch. So how to keep the tape on for longer? So there are some very simple things that we should always do with the tape. You want it to last really well, always round the edges. You can fold it over and do two at the same time. With a rounded, it's a bit like Velcro. You'll have heard me talk about rounding your Velcro edges before as well. So if you round your edges, it's going to stay on the skin so much better. Make sure that there are no creams or oils. If somebody has put nice cream on after they've showered in the morning, make sure you go and get rid of that outer layer of cream that sits on the top before you apply it. If you're wearing this for sport, the recommendation is at least 30 minutes before. To be honest, I tend to find 1 to 2 hours before is more successful at keeping the tape on. And then the last thing is that when you apply it to the skin, then if you actually rub the tape, now I promise Rachel I won't do this too much because we do want to be able to get this on and off all the way through. But if you rub it, you're heating the glue behind on the back and it will adhere better. So you're going to get very used to doing this rubbing technique to keep it in place. So then, how do we remove it without hurting the skin? Well, usually it starts to come away after 3 to 5 days or so. But this is usually a nice way. If you hold the skin and move it, it's much less painful. I would actually normally do it the other way. So going the opposite way to the way the hairs work on the skin. And so if you just run your finger just behind it as you tear it off, it doesn't pull on that sort of outer layer of the skin in the same way. There are times, of course, when you wouldn't tape. A really severe injury underneath, you wouldn't want to cover it up necessarily when there's poor sensation, because people need to know very, very occasionally people will get a skin reaction to it, or itching. Itching is usually a reason to say to your patient, just immediately take it off. It might be an indication of some blistering underneath, and blistering can happen, or more often happens, if there's tension on those anchors. If there's fragile skin, so I use it a lot with my hypermobile population, but I have to be very aware, particularly people with EDS are going to have very fragile, very extendable skin, so you've got to be really super careful. Broken skin, of course, is another reason. So what is the evidence for taping? Well, it's emerging. Thank goodness, it's coming. But very little of it has been done on hands. At the end of the webinar, I'm just going to run through a few slides that have got a few papers that pertain to hand and upper limb, so that when you're watching it back, you can actually pause the video and you can get those references, but I don't want to use the webinar time to run through them today. So let's start with taping for edema. So the first thing you need to do is learn your anatomy. So we need to know our lymphatic anatomy. And of course, we're always wanting to clear the chest first. So we want to make sure that the lymphatic nodules under the arm are nice and clear. So we're going to work up here. And we may well want to tape from the axilla along the upper arm, from the elbow along the forearm. But what I'm going to show you are some techniques for the hand itself. So this is where I'm going to make what I lovingly call a quintupus. So a quintupus is, in my mind, an octopus, but with 5 legs. So I'm going to cut along a piece that I had already prepared with some long tendrils up to about 2 centimeters away from the end of the tape. Again, everything's going to get rounded. I can actually do 3 at a time. So one of the things you really need is a really good pair of scissors. Okay, so here I have my quintupus. Okay, so here's his head. And what I'm going to do, imagine, as we know, always edema pools around the dorsal aspect of the hand. So you can either approach the back of the hand from the radial side or from the ulnar side. It doesn't matter. If it's really swollen, you might actually want to do both and have them crisscrossing. So I have just torn the tape just at the neck level of my quintuplus. And so I've got this part showing just the anchor. And I'm going to place the anchor over the volar aspect of the wrist. And I'm going to place it at an angle. I turn Rachel over. I'm going to place it at an angle so that the tendrils are actually leading up to the hand. And then what I'm going to do is I am going to take the tape and leave myself a little piece to hold onto. So I'm not holding, because you don't want to touch the glue. And now I'm going to let my creative juices roll. And I'm going to just place each different tendril. And what I'm trying to do is track the skin. Now, that very last bit never has any tension on it at all. And you're looking around 10, maximum 15% of tension onto this tape. Very little for edema. So now you can see I'm starting to capture some little holes in between. Works really well. Now, it doesn't matter. Your pattern doesn't matter. Just be creative. Okay. But essentially what you're trying to do is you're trying to capture these little holes over the back. And again, as I said, no tension on the end. Now, if I was going to keep this on, I would be rubbing each of the ends to try and eat the glue and make sure that that stays. But of course, I'm going to be taking this off, Rachel. But now, if she just makes some very gentle fists, you can clearly see the puckering of the skin. So it's lifting up the skin and increasing the interstitial space to give the lymphatics more space to drain. I'm also just going to show you a way of doing the back of the fingers. So say here is a technique for working the fingers. So I've cut a piece that essentially goes from the base of the finger to the distal interphalangeal joint. And I'm going to turn it into a little Chinese lantern. So I'm going to put some cuts along it. And you can see here, it opens out like a little lantern. Now, there are lots of different ways of taping fingers. I'm not saying that this is better than any other way, but what I've found over the years is that because it's got a closed edge at both ends, it does tend to stay on a little bit better. And we know that one of the issues around taping on fingers is, we're washing our hands all the time. So keeping the tape in place can be really challenging. So I folded back all the little tendrils and I'm holding it with one hand and with the other hand. And I'm just going to turn it upside down. And now I'm just going to place this over the finger. Again, I'm aiming to get some little gaps in between on those fingers. Now I'm going to use the very end, the distal end, and I'm just going to give it a tiny little pull and then nothing on the anchor. And I'm going to do exactly the same at the proximal end. So a tiny little pull and down. Now, you're going to be very annoyed with me. I hope you're doing this alongside me. I'm making it look really easy, but it's because I've done it a million times. It isn't that easy. And teaching patients how to do it for themselves, I mean, they get it. I tend to give people a little video to show them how to. Now, if Rachel begins to bend the finger, you can feel the skin on the top of the joint is really lifting up. Yeah.
But it feels still comfortable. It doesn't feel like I'm...
Yeah, it's not restricting.
No, yeah,
exactly. So it doesn't restrict, but you can clearly see as we move, it's lifting the skin really well. So again, if I was to do another finger, then I would cut it again, same from the distal interphalangeal joint to the end here, cut along, which is easiest where you fold it and place it in place. Super. Okay. Back to the presentation very briefly. I just want to show you some different patterns that we could use. So you can see here some taping that goes further up the arm. So you can see one that goes from the inner edge of the elbow coming along the forearm, and then you've got one on the upper arm, which is also giving you that taping. So you can tape all the way up and down. There's no need for it to be just here. You might want to do the whole arm. You might want to come to the upper arm to help clear you proximally. And here are some different ideas for how to tape the fingers. Like I said, my preferred is to do this little lantern, I think, without having the exposed edges, as you've got in the bottom left-hand corner of your screen and the top left-hand corner of your screen. It leaves exposed edges, and I do find that those come off more easily when you get the hand wet. Okay, super. So I had a little case, and this is exactly how I would tape for this gentleman. So now I've turned Rachel into a 62-year-old man, okay, yep, who's just had Jupitron surgery, but it got missed. He didn't come to hand therapy. This is actually based on a patient of mine that I had a couple of months ago. Had no treatment, and he had honestly the most enormously swollen hand. It was interesting, bless him. And it was pretty much splinting the whole hand. And we've done another webinar talking about edema and position of safe immobilization and all that sort of thing. So with him, I would tape him like this and probably up to the elbow with the fingers included as well. But that probably wasn't enough. So I would need to think about the other things, elevation and movement. So exercise, we know the lymphatics are much more effective if you're working in elevation and getting the intrinsic muscles working. But I might also suggest wearing edema gloves. So you've got these two types. You've got the ones with the 3/4 fingers, which are much more functional, or you've got the ones with the closed fingers if you've got edema right to the end. So I'm going to ask Rachel to put this on just to show you that you can actually put this over the tape and it won't interfere with the tape at all. You can have the two together and it's going to be completely fine. And now you've got the double working of, well, triple working, the movement, let's make it quadruple, the elevation, the movement, the compression and the taping all on at the same time. Fantastic. Do you want to just take all of that off? That's super. Okay. So the next type of taping I thought I would run through with you is scarring. Now, we're so used to doing manual stuff with scars. I don't use this hugely often with taping for scars, but sometimes our home programs are really overwhelming. There's so much for our patients to do that once in a while, we just want to give them a break from doing their scar management, okay? Or so, you know, we might really want them to have a few days concentrating on their movement, in which case it's really nice to have a taping option. So at least something's being done while they are concentrating on other part of their rehabilitation. Now, the difference here is we're going to be looking at 40 to 50% of tension on our tapes. So again, I had a little bit of a case study for you. So female, we're losing years, we're changing your gender. Excellent. Okay, had a distal radius fracture. We've got this very typical scar, which is longitudinal over where they've attached the orid, and they get so stuck. They really get stuck. They pull the skin in. We can start having problems with radial nerve and actually a median nerve on this side. So let's have a think about how we might like to tape Rachel in this situation. So I've got some small pieces of tape that I've pre-cut. Again, just a little eye cut. So the ones we did before are called a fan cut, the one that we did on the back of your hand. This is now an eye cut. And this time we're going to tear centrally, a bit like I did when I was just demoing right at the beginning. I'm going to fold the tape back, the backing back, and hold on to it here. So again, I'm not touching the glue. Now, if we imagine, I'm not going to poke you, I promise. If we imagine the scar is here along the front, then what I'm trying to do is I'm trying to go at a 45-degree, then a 45-degree angle going up the scar. All right, so I'm going to hold this. This is no tension, 50% tension. Place that down. no tension on the anchor.
Mhm.
Same again, tear, open out the outside. We're going to go directly across it, tension, no tension on the anchors. And now I'm going to herringbone this up the arm. So now I'm going to come up here again. You can see I've gone to 50% because my hexagon has become a hexagon, and then no tension on the anchors. Yeah, 50%. So my line of scar, you need to put your skin in. Yeah, it's quite a weird feeling. Okay, and then we're going to do again and cross over. And I would just basically keep going. I only cut out 6 just to show you. But again, I've managed to get a hexagon on this length, so I can tell when I'm getting that 50% stretch and across. So my line of scar is directly up the front here where they are crisscrossing over each other. Okay, maybe I should have done alternate colors so you could see. But I think you can see.
Yeah.
And now, as you move again, as you move the wrist, in fact, you can see it puckering a little here, but you can feel it really pulling you up, can't you?
Yeah. But again, it's
Doesn't stop you. Yes, doesn't stop you
No.
moving.
No.
Beautiful. So you can still concentrate on your movements and your other therapy. Super. Again, if this was a real patient, I would be teaching them to rub it so that you're heating the glue, but we're not going to do that. We're going to leave it. We're going to take it off nice and quickly so that poor Rachel's skin isn't red raw after the end of this webinar. Again, you see, I just held the skin down to pull it off because that makes it so much more comfortable. If only I was this neat at home. Okay, so just a few other things just to think about. Of course, we can use silicone products. So we can either use these lovely silicone sleeves that go over the scar, put some pressure. If you don't have these large ones, which are slightly more difficult to get hold of, you can have these finger ones. But what I've realized you can do, of course, is you can slit them down the middle. And now I've got a really nice lined piece. So, oh, well, I have to say most surgeons are going to take a little bit more length to get their orif inside, but there's a nice short one. And you can actually just bind that on with some, either with some micropore or just with a bandage over the top, and that gives you the silicone on there. So you can actually use the finger ones down onto this area. And then we've got things like suction. I really like these. You can just pull on the skin and it lifts because it's sucked down, hasn't it? So we want to really lift it up. So never leave them on. Few seconds, give it a little bit of a tug, let it go. Few seconds, give it a bit of a tug, let it go. Little kisses.
Yeah.
Okay, super. Right, let's have a look at the next way of using tape. So muscle inhibition. So now we have the intention to try and reduce the use of the muscle and change the way that we use our hands. So just imagine that we've got an acute decurvent or first dorsal compartment tenosynovitis. Okay, I'm going to take a piece of tape and I'm going to measure from the base of the nail till about mid forearm, and that's because it's actually going to increase in length when I use it. I'm going to turn this one into the shape of a bottle. So I'm just going to make the distal part a little bit narrower so that you can see. Now, Rachel's got beautiful nails here, but I think they've just been done. So I don't want to stick onto here, but on a patient, I would normally stick onto the nail because tape sticks so well to nail that it really helps it stay in place.
You're welcome to. I only did them myself.
Oh, you did? Oh, it's okay. They're not expensive nails. Okay, all right then. So what I want to do is I want to try and get the radial side of the wrist, not just a little bit tighter. So I'm not allowing her, or she's getting proprioceptive feedback when she moves into ulnar deviation, which we know is going to stress everything. When she moves into, she gets that sort of reminder that she shouldn't be moving that way. Or when she brings the thumb into flexion, again, she gets a reminder. So what I'm going to do is I'm going to attach this with permission to the base of the nail. And again, I would normally keep that. And then I'm going to ask her to radially deviate and extend the thumb. Okay. Now we need to follow the pathway of the muscles. And I'm going to make a bridge. And I've made a bridge across here. So you can see there's a big gap. If I turn this way up, you can see I've got a big bridge there. Now I'm going to ask her to very gently bring the hand into position. Beautiful. There we go.
Oh, yeah, that's.
Yeah, feeling that?
Yeah.
Okay, so now this tape is basically trying to hold her in this position. She either on the deviates the wrist or don't go there.
Yeah.
Right, so it inhibits muscle use. Turbans, and you wanted to enhance the use of the muscles, and you wanted to work on, say, the abductor, and the extensor pollicis brevis, then what I would do instead is, instead of having that bridge, I'm going to use a muscle enhance. So that means I'm actually going to apply the tape with the muscle in an elongated position. So I'm going to show you that with the common extensors rather than these, because really well for that common extensor muscle. Yeah, beautiful. And the nail's intact. Look at that. Okay, so common extensor muscle. Let's have a little look. So this is a very, very typical patient of mine, because I specialize in musicians, so maybe 70–80% of my patients are musicians. Pianists often play with very rigid wrists. They need to learn to we soften them. What you can't see in the clinic is there's a piano over there. So we teach people to soften because muscles like to go on and off. They don't like to be on all the time, but pianists often leave these on all the time. It's also really good for lateral epicondylitis. When you start getting these really nasty sort of myofascial trigger points into the muscle, most of the time you go into this muscle, it's just a little bit miserable.
Yeah.
It feels not so
Yeah,
bad,
that's
actually.
lovely, yeah.
Yeah. Whereas, but if you went into mine, you would feel some nicely knotted muscles from tennis. So this would be an example patient of mine, pianist, at conservatoire, studying classical piano, very rigid wrists, overuse syndrome of the common extensor muscles. The wrist extensors are on all the time. So I want to try and enhance them and get them to work a little bit better. So I'm going to cut a piece that is the length from the elbow to the wrist. Oh, that was a good guess.
Yeah, perfect.
Yeah, elbow to wrist. So what I'm going to do, now it's interesting, one of the studies that I've put at the end of this is that they've looked at whether it makes a difference, whether you apply proximally first or distally first, and the answer in that paper was it makes no difference at all. So I tend to work proximally first. So I'll work with the muscle and I'll be using nice, massage tools like this. Actually, this is beautiful, but I quite often use a tennis ball, no end of those available, and I just give them to my patients. But this is lovely because it rolls around. This is a tiger tail massage tool, which is really nice. It's actually, for my arthritic thumbs, it's really nice because it's slightly tacky on here. So ergonomically, that works really well. So I would work on this. If I've used any cream, off she goes to the sink, washes it all off, and then we go from there. So we are going to work out which muscle group it is. So we won't do that, but we will go above where the muscle is at its most knotty. Again, I would attach that just to make sure that this is going to stay in place. And then I'm going to ask her to place the muscle at length. So we're going to extend the elbow and drop down the wrist. Beautiful. I'm going to take the central part of the tape off, backing off, and I'm just going to place along the muscle while the muscle is in that stretch position. Bring her back into comfortable position, take the stretch off the muscle, and just finish off the tape. So again, anchor, anchor, active bit of tape. Okay, that works really, really nicely. If there's a really big knot and you found one specific place, then I do quite like to do a little extra, which is to take another piece and where that knot is at its worst. So find that spot, and I will do a bigger stretch, so like a 40 to 50% stretch. And I will go directly perpendicular. So again, I'm going to feel, I can tell because I've got a, I don't know if you can see it, yes you can. I've got a nice hexagon here, so I can see when I've got 50%. Pulling that across, again, anchor, anchor.
Yeah.
Right, you can feel
Yeah.
and that really lifts everything up. And this enhances the muscle and works really well.
Yeah.
So that, oh, I'm rubbing it. It's complete instinct. I'm so sorry. I told Rachel she had to kick me if I started rubbing this because it's so instinctual.
Yeah.
So anyway, okay, so this is how I would enhance a muscle. Okay, excellent. So we can say, oh, we can leave that one on if you like for now. Let's change tack again a little bit and let's look at osteoarthritis of the thumb. Now, in fact, I should be the patient here rather than Rachel. I should have taught you how to do it on me because my thumbs are, really suffering. My arthritis is quite bad now. And, it's this, particularly my right is beginning, I've got the shoulder sign beginning to come. That picture, in fact, on there is me. So I've lost a little bit of range. You can see I'm losing my first web space. I've held it at bay for about 20 years, but it's catching up with me. And when my CMC area is really sore, I love this. It's like giving your thumb a hug. It's bizarre, but honestly, I call it the smile technique because we're using a smile shape, but it is literally like giving the thumb a hug. All of these are possible for patients to do for themselves, but it takes a bit of practice, to be honest. So I will teach patients to apply the tape just down on the radial side of the base of the thenar eminence. And then with a little bit of tension, I follow the thenar arch. And then no tension at this end and no tension at this end. My ideal would be these two actually just meeting here on the back. And I usually use 2 layers. So again, attach down here, little bit of a pull coming through. That's the active part of the tape. This is not the active part of the tape. Here to here. And you feel that.
It feels exactly like you said, like a hug on the thumb.
It is like a hug on the thumb.
Yeah.
It's bizarre.
Yeah.
It really works. And it just seems to just pull, that volar subluxation that's beginning to happen. If you don't want to limit function by wearing splints and things. I mean, I love splinting and love making them for people, but ultimately this is a really good first if we could get these thumbs referred to us nice and early, it's a really nice way of doing it. Okay. Now, the other thing is actually, of course, you want to do this alongside teaching the exercises, alongside teaching the joint protection techniques. And the whole thing together makes makes the whole treatment. It's not about just taping. I've also found, now this is really bizarre, please don't ask me how or why this works because I do not know. But I have a lot of people who tell me that they've got arthritic pain, bit of crepitus in the DIP or PIP joint. Okay, so remember that little lantern technique that I taught you for the edema? Well, this is the really bizarre thing, and I don't know what made me try it, but I tried it. When my joint was really clicking, my IP joint of my thumb of my right hand sometimes gets really miserable, as does the middle finger PIP joint. So I just was experimenting on myself. And again, let's imagine that Rachel's come to me and she's just said, you know what, my PIP joint is really sore. And every time I go into flexion, I can feel it grating. It's a little bit painful. Well, it's just so bizarre. If you put this little lantern in exactly the same way that we did for the edema, with exactly the same 10 to 15% of tension on that painful joint, honestly, patients will look at you and go, well, hang on, I don't get it. And they can literally move and the pain is gone.
Yeah.
Like I said, do not ask me how, do not ask me why. It works, right? Taping is all about imagination. Try it, see how it works, see how you can go. It's bizarre, it works. Have a go. So I hope you're actually taping along with us. I know I'm going super fast, but you know, it's just really nice to practice together. Brilliant. Should we take some of that off?
Yeah.
Yeah, you're getting covered. Let me take that away for you. So you've got two hands. Ooh, there you go. Okay. So I also just wanted to show you, if we go back to the presentation, I see an awful lot of people with hypermobility. So hypermobility, I often want to do a proof of concept, I think is what I would call it. So I want to be able to see whether, if I control the hypermobility of the joint, whether I can change the muscle recruitment. Because as we know, very often the extrinsic flexors will have taken over, the intrinsic flexors will be doing much less than they should be doing. And I want to stabilize these joints to help them manage whatever functionally they're trying to do. But sometimes putting them into splints is a bit too much. So I might use an oval 8, of course, as a proof of concept, but I quite often want something that's dynamic. So I've fiddled with this a million different ways. Okay, so I'm going to show you a couple of different ways. These are a little bit short. So if I was to try to help Rachel with hypermobility in, say, her middle finger, we did actually discover, in fact, that her middle finger can fall into a very delightful swan neck. So if I show you here, you can see that Rachel, if I turn you this way up, you can see that she is actually hypermobile in that joint. So she is falling into a swan neck. Not huge, but just a little. So if I want to try and hold her in this position, here's a couple of different ways of doing it. So you can, again, there's no tension on there. I've just put this tape on the back of the finger. I'm going to flex the finger down here. And I'm going to put some tension now onto the tape as it comes up and through onto the middle phalanx. Same here with this one. Keeping that PIP joint flexed, I'm going to bring this up and through and underneath with a bit of tension, no tension at the end there. Then I'm going to do exactly the same the other way around. So I'm going to come on the back of the middle phalanx, and now I'm going to bring this underneath, and I'm going to put some tension through here, and again, no tension at the end, and again, no tension there, tension. Flex it down a little bit, that's it. And here. Now, that's locking in.
Yeah.
Allows for extension, allows for flexion,
Yeah.
but just gives that little bit of stability. Yeah, and this is a proof of concept. So if somebody doesn't want to invest in a splint, and for me, silver splint, whatever, then it's a really good way of getting the muscles to recruit in a different way, of giving you functional stability, seeing whether it helps, proving the concept, and then moving on to something that's maybe a little bit more rigid. So this works really, really nicely.
Yeah.
I'll take that one off, okay, and then I'll show you, because I fiddled with lots of different ways of doing this. So I'll show you one other way that I've been doing this for hypermobile joints, and that is to come laterally on the joint. So if I ask Rachel to just very gently bend a little, it's beautiful. And I'm going to come, I'm almost basically being lateral bands. So I'm coming along the side. This works really well for lateral instability as well here. So the tension is along the edge. And then I'm going to do the same again. Bring it along the side here. Put some tension along the edge. No tension on the anchor. Tension along the edge. No tension on the anchor. And now try that one.
Yeah.
Same thing, gives a little bit more lateral support.
Yeah,
so
it
if you're
does.
unstable sideways, then that can help. It's just a different way.
Yeah.
Experiment. Different people's fingers work in different ways. You can do exactly the same technique, that wrap over technique, starting here, coming underneath for these unstable MCP joints as well. Okay. Pop that one off too. All right. I'll support you with your fingers. Definitely being abused here. All right, back to the presentation. So here we had a case study for hypermobility, but what I'd really like to do is in the last few minutes before we go to questions is move on to the next slide, which is, well, what other ideas do we have? There are so many different ones. So here are just some, but you can work your way through a whole load of different ones. So proprioception, we need to know obviously where our hand is in space without vision, our joint positions sense. And so sometimes it can be really helpful. If I'm trying, for example, to train a pianist, and we'll look at this from two ways in a minute, to stop her from ulnar deviating. So often pianists will do this, but they'll ulnar deviate when they work. So what could I do? I could take a piece of tape and I could put it on just for training. I can put it tight on the radial border. And now every time, can you feel that?
Yeah.
So every time her brain, even without looking, she's going to get that constant reminder, don't go there, don't go there. Yeah, so literally I can use it for training and I love it for that. Okay, so that's one idea. Now, I've got a little bit of video to show you. So this is a video actually of a lady I saw this morning in my clinic. And you'll see that she's got some black tape on her. So if you want to play that, Chris, that's brilliant. And what I've done is I've put one piece along the third metacarpal and I've put one piece along the central forearm. And she's just able to watch herself and see if she can keep them in alignment without pulling, there you go, right into that ulnar deviation. So again, it's just a lovely visual cue. That's another way. Brilliant. Thank you, Chris, very much. Subluxing sagittal bands. So I've seen a fair few of these, and I've managed to just tape around the edge, the lateral borders of the MCP joints to try and hold those. That works also really well. And then another one that I'll show you is the irritated sensory branch of the radial nerve. So the radial nerve gets irritated here so often, and we're going to want to do our lovely techniques of scraping and trying to release it out from the skin. But once it's a little bit less sensitive, then this works really, really well. So if you work out which way, when you traction on the skin, so I'll normally do this and say, feel anything? Has anything changed? And I go, it's fine, but it might be that when I pull this way, they suddenly get pains and pins and needles and changing feelings up, usually up the index finger, but it can be anywhere. And once we've desensitized it a little bit, I can actually just put the tiniest bit of tape on here and just give it a tiny pull. And it stays on. And it's, again, very easy way for the patient to just desensitize it tiny little bit with a pull, and there. Sensory branch radial nerve. So like I said, loads of different options. Thank you so much to my victim. What I'm going to do is I'm going to just slowly go through these slides with some of the evidence on, while Rachel just gets herself in. See if we've got any questions. So there is to look through. So we've got an alternative with compression bandages in lymphedema. That works really well. Next one, we've got some use of tape for hypertrophic scarring. So there's a couple of papers there. One that's comparing to deep frictional massage. And then we've got, does the tape, the one I mentioned earlier, does the direction of the tape make any difference? And the answer actually, I'll save you bothering to read that paper. Basically, the answer is it doesn't. And then we've got a systematic review of papers talking about taping for decurvans. Again, there was a meta-analysis done saying that the number of papers is tiny, absolutely tiny. So we are nowhere near really even these systematic reviews giving us useful data. The numbers in these studies are tiny, the number of studies is tiny, and actually we will over the next 10 years, I think, see a massive increase. And then taping for muscle enhancement, you've got a fascinating study here that you can see on the right hand side, which basically talks about if the patient believed it, they felt it did really much better. But that's the same with all therapy, isn't it? Yeah. It's just the same with all therapy. So yeah, if you believe the tape is going to work, then it did work really well. And then I think finally we've got one where there were two studies looking at the use of kinesiology tape in osteoarthritis. So I will leave you to find all of those studies if they're of interest to you yourself. That is pretty much a summary of what's available in the literature. There's loads on lateral epicondylitis, but pretty much not a lot else. So I'll leave you to find those papers yourself. So do we have any questions?
Yeah, we've got a couple. So if anyone's got any others, then please put them in. So a couple of questions about will we be able to print off the slides because they'll get a copy of the recording.
So anyone who is live, when you get your certificate, you'll get a copy. Obviously, you'll get the whole presentation, so you'll be able to just replay it whenever you want.
Does the technique for scar management help with carpal tunnel syndrome?
Interesting one. So I've seen a couple of papers written about carpal tunnel and the use of tape. Now I'll show you, there's a particular technique, I'll show you on me, that is, there are two actually, there are two that I've seen used. I've never used it because I'm going to be honest, I'm just not sure. Because even if I lift the skin here, has it really lifted that flexor retinaculum and increased the space in the carpal tunnel? I'm just not convinced, but I'll show you the two techniques that are out there. One is this central stretch one with a 50% stretch over the front of the carpal tunnel. So with a stretch here across and then coming dorsally with no tension. So you'll see this one written up and it does pucker the skin. My question is it really making a difference deep down? I'll make a lovely study if somebody would like to do that. And then the other option that I've seen is people have done taping from one side and they're actually lifting with tension, bringing it dorsal with tension. And then there's no tension over the back. And then tension in this bit. And this is a bit long. Always cut the tape with the backing on. So this is really basically pulling it outwards. So I've seen this as a taping technique for carpal tunnel as well. But I have no personal experience of that, whereas everything else I've shown you today, I've used with success.
Would taping a sagittal band injury be seen as an alternative to splinting in relative extension? Oh, I've lost the other question. Or would it be used after the patient comes out of a splint?
Either and both. I think the thing to recognise that is if the sagittal band is so injured that it needs surgery, it needs surgery. And one of the things I've discovered is that, you know, I don't think taping can resolve unless it's really acute, maybe with an injury. Most of the sagittal bands that I'm managing are those that are really stretched, again, hypermobility. You're just seeing that the extensor tendon is not running smoothly over the central head of the metacarpal phalangeal joint. So I've been using taping just to realign that and give a little bit of lateral support, and that works pretty well. But I don't think it can replace surgery. But I think it can be either to see whether you need a full splint, you could try it because it's going to give less support. You could also, particularly if it's an index finger, you can actually protect the sagittal band by supporting the ulnar side of the index finger, pulling that a little bit radially with a piece along the lateral border here, which prevents this constant ulnar deviation through function. I've tried that, and that works really well. But I often will try taping, I'll try splinting, and I'll try exercise, and I'll just look at which of those three is the best for that individual patient.
Yeah, thank you. How about using it for CRPS/pain? Any experience with that?
Really good question. I think for pain, oh, actually, no, let me take the CRPS one first. I have used it relatively recently with a CRPS lady who was so muscle inhibited because of her pain and because of her fear, and it was really horrible CRPS. I did use it to enhance the use of the extensor muscles, because psychologically she found it. I actually used a neurostimulator as well, bizarrely, which I wouldn't normally do, but she found it really helpful to have that assisted extension, so that she had the belief structures that she wasn't having to do so much hard work. So I'd say for muscle enhance, sometimes that's a really useful thing. For pain, if it's hypersensitivity, then you might want to just check that none of the digital or peripheral nerves are irritated, and I will use tape to settle down the digital nerves to try and help reduce pain. When else have I used it for pain? Well, obviously, if I'm trying to stop a particular movement, so if there's a ligament disorder and a ligament sprain, you might need to immobilize first, of course, while it's healing, but then as you start to allow more function, then you might want to give some lateral support to that joint. So that again is pain prevention and re-injury prevention. So I'll use it for that as well.
Questions have come flooding in now.
Oh
so
gosh, sorry.
No,
It's got 6 minutes.
Yeah, we may not be able to answer all of them. How long after can we start taping scars? Okay,
The scar, that's a really good question. I wouldn't start taping a scar until it is really healed. So I would leave it at least 3 days, 4 days after skin closure. Basically, if that skin is closed enough for you to be doing your frictional scar massage and your suction and your vibration or whatever else you're using, it's good enough for doing taping as well.
How do you decide how many strips you cut on the tape for edema or lantern style tape, or is it always 5?
It's a bit random. So how many? So I do try and get 5 if I'm doing the edema, because I just think for one strip that's about the right thickness. If it's on the hand, I tend to do 4 if I'm further up the arm, because obviously you've got a bigger area, and so we can cope with a wider strip. So I suppose if it's up on the forearm or on the upper arm, probably do 4. And then when it comes to folding for the lantern, oh, and by the way, you might think that we could cut, because this is about the right length for a finger, okay, isn't it? But you can't. you can't cut that way because it's a two-way tape. So you've always got to cut up and then across. So I tend to find it's however many scissor cuts I can get to fit. So normally it's 3 or 4. So 1, 2, 3, 4. I've actually got 5 cuts in that time. But I will try and make sure that it's at least 3, if not 4 or 5.
You tend to apply with 50% stretch, whereas I was always taught 20 to 30% for hands.
So no, that's not quite right. So my amount of stretch depends on what I'm using it for. So again, if you go back to Kaz's original book, he's really, really clear that for edema, so for lymph management, it should be very light. So we're talking 10 to 15%. And so that's what I showed you. For muscle and for scar, again, he describes using between 40 and 50%, and that's irrespective of where you are on the body. He doesn't differentiate. It's the purpose of the tape that distinguishes how much tension you put on. However, what I would say to you is, right as I said at the beginning, always do less rather than more.
Yeah, perfect. So we've still got about 30 questions open.
Oh my
so
word. Okay.
we might have to
I
list.
always get a list afterwards if there are questions we haven't managed to cover.
Yeah.
So don't worry about that. I will answer everybody personally if their questions are there.
So we'll do this last one. Is there a particular taping you can do for a suspected TFCC tear?
Not that I've found. I've done a really nice pisiform lift, so sometimes that can be really helpful to offload the on side of the wrist. I'll show you how I would do that. So I would put the anchor down on the pisiform here, and then I would place I'm really putting an AP stretch here. So I'm lifting up. So I would lift this side of the wrist. Sorry, there. Cross, and then nothing here on the anchor. So that's now lifting up the other side of my wrist. I found that can be quite helpful with the long-term grumbly ones. But other than that, for acute tears, no, I haven't, other than to either enhance or inhibit the muscles that you want to work more or want to work less.
You can just go back up, Chris, that's on that. So we've got one about, I work in acute stroke. I've used it a couple of times with patients. Are there any other contraindications I should be aware of? I mostly consider skin integrity and cognitive behaviour, tactile tolerance, etc.
Absolutely. Now, I'm not a neuro expert. I'm a hand therapist, musculoskeletal based completely, but I work in a team with a couple of neuro rehab OTs, and we have used taping with them. But those are exactly the things that we think about. Skin tolerance. Sometimes the hypersensitivity to the feel on the skin is enhanced. So just to be very aware that the proprioceptive reception of it can sometimes be more than you're expecting it to be. But other than that, I am not a neuro specialist, but I'd love to learn from you. So I will get back to the rest of the questions. I usually get sent them afterwards. Just to say that Performance Health has got a 20% off taping for the rest of this week. We weren't able to extend it, which is a bit, but there it is. Try and get your orders in this week if you want to order some. But also Rachel was telling me that she's been working with the supply chain into the NHS. So all of the prices have now been corrected and improved for taping into the NHS as well. So it's worth having a look at that. And that's permanent. Yes. Yeah. So that just leaves me to say thank you, goodbye. I've got another one in the autumn. So I'll see you all then. Thank you so much to Chris and to Rachel, and see you all soon.